Can you hear me?
Yes, Enrique, we have also welcomed the first participants in the meeting.
Yeah, so I have just called our speaker, welcoming everyone, and he's joining us now anytime soon. So
Great.
we'll be
So
able
we
to
can wait
start.
1-2 minutes also for participants to
No,
join.
he was just connecting. Yes. Um,
Perfect, and here we are. We are all set. We have participants joining. Welcome, welcome. I think we can start, Enrique.
yes. Good afternoon, everyone, and thanks for joining us. We are moving ahead with our XiA program, and basically one of the things that we know is really important is to convey the message about interoperability, namely the European Exchange format, which is at the core of the XiA content and materials, educational materials we want to develop. And of course, the perception is that interoperability is often mostly for technical people, both the developers and the implementers of electronic health records and other digital health solutions. But that's not necessarily the case. We believe that we need also to prepare the end users of electronic health records and digital and clinical systems, because in a way, clinical practice, while I believe no one wants clinical practice to change because of interoperability. Rather, it is to be facilitated with improved interoperability, connectivity, seamless exchange of data. We also know that we want to boost changes also in clinical practice, that changes that make sense. So in order to discuss that, today's open learning session is dedicated to preparing clinical practice for the concept of the European health data space. And this brings about cross-border care, integrative care, cross-regional, intra-border care, and the challenges of integrating care, which still remain. So we now have all our three speakers. So I'm very happy to see that. And maybe someone we can move to the next slide, so I can quickly tell you about these three friends. So it's my honor to introduce, without any specific order, Professor and CEO of her own enterprises, Wuleta Lemma. She collaborates with us in XiA. She also collaborates with Lusófona University. She has a very, very extensive curricula, working and having worked in the US and with a significant footprint in Africa. She is now also interacting and learning about the European health data space. She has a clinical background, public health background, and of course a digital background. And I believe she's now doing her second PhD in AI. To her right on the slide, we will have Juliana Sá. She has been collaborating with us as well, but she is located a little bit more north than Lisbon. She holds a master in medicine, so a degree in medicine. She's currently finishing her PhD in medical education in the areas of professionalism, and she teaches and educates medical students for a long, long time, as well as she is a practicing clinician in internal medicine, which gives her a very clear and capable footprint onto understanding the implications of these digital transformations in the real world setting. And finally, last, because he was the last to arrive, but thank you very much, Brian, because much earlier in the US for you than for us in Europe. Thank you very much for joining. Brian Dixon is Professor and Director of the Center for Biomedical Informatics in the Regenstrief Institute. His work has spanned far beyond the U.S., both in interactions with the African continent, and more we see him flying over here to Europe in different conferences, talking to us about informatics and data, and I believe that he can bring that perspective also on how to educate for clinical practice, and having understood clinical practice in the broader sense, comparing it across different regions and different data and information domains across Europe, across the world, I wanted to say. So thank you very much, Simon, also for putting up all this, and Luke from our communication work package for putting up the session. So for me, it's always the easy job. It's just to welcome everyone. Thanks all for joining us. You'll have time to make questions. If you don't, please use chat functions or just LinkedIn function or any function, and feel free to reach out after today's session with further questions to our speakers, and also about the project. I'm aware we will be recording, but it's always different to have it live. So thank you very much, and over to you, Simon.
Thank you very much, Enrique, and thank you everyone for joining today's session. So the agenda here, you're going to see in order. We're going to have intervention by Brian, then by Wuleta and by Juliana, and finally we will end with discussion and the Q&A. So for everyone that is on the Teams, you have a Q&A function where you can send us your question, and please do so. You also have a meeting chat if there's any issue or any other topic to discuss. I will just say 2 words about the project. So for those who don't know, the XiA project is a 4 years project funded by the European Commission that aims to build capacity in the health workforce around Europe for the European health data space, and therefore about advanced interoperability of health data and health systems. We have more than 40 partners in 20 countries. We teach about 3 groups of topics, and we call them families, and in total they are 20. We have the essentials and transversals family. We have group of families. We have the HTS and systems component group of families, and the standards and semantics. So we go from general to specialized and advanced topics. If you're interested, you can already scan this QR code to join the movement and see all of our social media links and other places where you can learn more about the rest of the project. And this QR code will come back at the end of the session. And without further ado, for the purpose of time, I will hand over to our first speaker. Brian, this is over to you. I can move the slides for you if you like. Just let me know.
That'd be perfect. Yeah. Thanks, Simon. And thanks, Enrique, for the introduction. So good afternoon, everyone. As Enrique said, I'm Brian Dixon with the Regenstrief Institute and Indiana University. Next slide. I'm going to start by talking about biomedical informatics. Next slide. Just briefly to level set what informatics is, and especially from our perspective here at Regenstrief, and certainly the way we generally view it in the US, is that it is a science of information, and I think that's a global definition for informatics, where we study the representation of information, how it's processed, how it's communicated by computers, humans, and organizations. So I always like to stress that we're interested in not just the computer, but also how people use it and how it fits into organizational systems. Next slide. Biomedical informatics is a broad field that encompasses a number of subdisciplines. I've worked mostly on the right-hand side of this graph. I focus on public and population health informatics, working with health systems and ministries of health in terms of organizing information and using information to drive both care decision-making as well as policy and surveillance of disease. But certainly our field encompasses everything from the genome all the way up to the population level work that we do, and it's quite a spectrum, with most of the clinical informatics happening at this intersection. Next slide. I wanted to start by offering, since we are a science of information, a theorem, and this is what's known as the fundamental theorem of biomedical informatics. At least historically, it has been this top line, which is that the human and the computer working together will always be greater than the human or computer working individually to make a clinical decision. This has been recently expanded in the era of AI. I put the URL to this new paper that just came out at the bottom of the slide. I think it was published last week. And so the updated version of this theorem states that humans, computers, and AI in assisted medicine working in a learning health system will always be greater than the human working alone, the computer working alone, or AI assisted clinician working in a silo by themselves. So I think it's a great update to the fundamental theorem. But what's driving behind the theorem and the postulates all center around the fact that humans and computers work together inside of systems, and that the teamwork, if you will, therefore is more powerful. That we want to design systems that are usable by clinicians, and we also want clinicians to use their human judgment, their decision-making capacity, their clinical knowledge and expertise to be the ones guiding clinical practice with some support from computers working inside of health systems. Next slide. And that brings me to a lot of the work that I do, which is at the population level. So I wanted to give you an example of where interoperability comes together with clinical leadership and public health leadership to drive innovation and improvements in population health. We call this the MINS network, which stands for Multi-State EHR-Based Network for Disease Surveillance. So it's an interoperable network around the US, and it's been more or less in a pilot mode for the last few years. Next slide. This is just a representation of the different sites across the United States. I am located in the blue one, so that's us there in Indiana, but we work in partnership with a group out of Chicago and Louisiana and Colorado, and then up there in Washington State, in Seattle, to build this network. Next slide. Fundamentally, our network, I think, highlights the benefits of interoperability. So data is captured in the clinical EHR that's used in the hospital, in the primary GP practice. It's then shared as part of what we call the Indiana Network for Patient Care. So that's the light blue arrow to the right. And that's our XiA network. So that's where we incorporate LOINC and SNOMED and standards and interoperability to bring all the data together. And then what we can do from that is we can link individual records across the different hospitals and places where a patient has received care. We can then create population level aggregate summaries of information around chronic disease. And then we can de-identify that data at the aggregate level and share it with public health, which is where it's then visualized and used to support decision making. So next slide. For example, one of our early targets was hypertension. We wanted to look at hypertension prevalence stratified by sex. You see down at the bottom in the light blue, by age group, which is in the darker blue, and then in the salmon color to the right, that's based on race. And we can look then at prevalence by various groups in our community, and this is at the state level. Next slide. We can also then visualize it by geography to look at those counties that have higher levels of prevalence and lower levels of prevalence in order to understand the distribution of and burden of disease across the state. Next slide. We can also look at this at the state level. So this is within a county. This is Marion County, which is the home of the city of Indianapolis, if you've heard of it. Indianapolis 500 race that happens here. And in our county, we also have stratifications of prevalence of disease by zip code. So we're looking at the US zip code here, and you can see that there's one area in the center right of the graph that has very high prevalence of hypertension. Other areas have moderate levels of hypertension. And so this helps our local health department in making decisions about where to, which health systems to reach out to for partnering, for screening, for education, to have fairs and offer educational resources to patients, to engage with communities for primary prevention. Next slide. We also use our health information exchange to monitor hypertension control. So it's not just about finding disease, it's also about monitoring those patients that are doing well on medication. They're engaged in care, they're doing what they're supposed to be doing. Perhaps they're lowering their risk factors for hypertension. So this graph shows the darker colors here are those that have higher levels of control versus lower levels of control. Again, if we're thinking about secondary prevention efforts from a population health perspective, this is where health systems and public health would want to engage with those communities with lower levels of control about how to ensure that patients are engaged in care, receiving their medications, and supporting their health and maximizing it, even though they may have a condition like hypertension or diabetes. Next slide. Critical to all of this is clinical leadership. Next slide. So there's a lot of ways that clinicians lead in informatics. A primary role is that they are champions for interoperability, where they can advocate for interoperable solutions and engagement with other health systems to share data for the patients, for the benefit of patients and population health. And they can provide input into system design, planning, and the ethical use of technologies like AI that we're rapidly adopting now to ensure that those are being used in a way that guides clinical decision making, that's done in a way that supports clinicians, but doesn't take the place of clinicians' expertise and knowledge. Second, they act as models for others. They can teach how to use the XiA interoperable solutions. Some of my work has been looking at how XiA is being used in Indiana and the US, and many times clinicians learn by their peers. They learn by seeing something cool that their peer is doing with the XiA, with data that they're getting from outside their own EMR system, and then they're able to replicate that and start working it into their practice. And so that's a primary way that clinicians can lead in interoperability. Also, to think about and innovate in these systems and provide ideas to leadership, to the chief medical informatics officer, to others on how they can better scaffold informatics solutions within their hospital or within their health system. And also in working with the patients, helping them to understand the benefits of interoperability and why sharing their data is important, so that we can, for example, track pregnant mothers as they move throughout the healthcare system in the prenatal period to ensure that they're getting the right screening, the right testing, the right care to maximize the outcomes for both baby and mom. Next slide. In the US, we actually recognize informatics as a clinical subspecialty. So it's recognized by the American Council on Graduate Medical Education. We have a program here at IU and Regenstrief that we train future clinical informatics leaders who are board certified in the US. And that board certification is offered by both pathology and preventative medicine branches of medicine in the US. And then, in addition, the American Medical Informatics Association in the US offers what it calls the Health Informatics Certification Program, or AHIC, and that certifies non-physician informaticists with various clinical backgrounds in order to provide that leadership as a mark of certification, so they can go back to their organizations and lead informatics projects in their organizations, including ones centered around interoperability. Next slide. Last, I just want to say that I know we're talking about interoperability and standards today, but recently my university launched a really cool online course called XiA 101. It's focused around teaching people how to use generative AI technologies to make their work more efficient. And we recently made that course completely free to the world. And so I've taken the course. It's really well done. First, we offered it to students, and then faculty and staff, and then alumni, and now we're launching it to the world. So if that's of interest to you, I would encourage you to check that out, and it may help you, not necessarily with interoperability, but certainly with how to think about the responsible ways we could be using AI in medicine. Next slide. And last but not least, our organization is the home of the LOINC data standard. That's one of the families within XiA. We will be having a conference in Cologne this fall, so I look forward to traveling to Europe then as well in order to meet with European colleagues and others about how we can advance LOINC and data standards, semantic data standards in the healthcare system. And that should be it. Next slide. I just wanted to leave you with this message that the success of the European health data space really depends on clinical engagement and leadership to employ, to deploy, implement, and use interoperable solutions that benefit both our patients as well as our populations. Thank you so much.
Perfect. Thank you very much, Brian, for your intervention. For the participants, if you have any question, please send them through the Q&A function. We'll address them at the end after all of the speakers' interventions. You can also use the chat function, and here you have contact details of Brian to reach out directly to him. And with this, I would like to hand over to Wuleta, our second speaker. Wuleta, you would like to share the slides from your side, right?
Thank you, Simon. Let me. You can see my slide?
Yes, perfect.
Thank you. Thank you, Simon, and thank you, Enrique, and organization of this presentations. Today, I'm asked to say something about electronic medical record. I would like to divide my presentation broadly on electronic medical record and my experience. I've been working on implementing electronic medical record more than 15 years, mostly in Africa, but also I've been working on electronic medical record in the US. So basically, when we talk about electronic medical record, it's not about charts or digital charts we are talking about. It's a journey. It's a clinical data infrastructure that enables safer, we hope, safer care, continuity, interoperability, analytics, public health reporting, like Brian mentioned, and then responsible AI. So just to, since I have no idea, the audience may be in some who have used electronic medical records and some who are thinking of using it. So just to be on the same wavelengths, an electronic medical record is a longitudinal digital person-centered record for health information created and used by authorized health professional across care settings. So in many places, we have in paper-based records, mostly in the places that I've been working for the last number of years, but it's not only just digitizing paper. It's about the core clinical content, demography, history, medication, allergies, vitals, notes. In some of the places I've been working, sometimes some of these informations are not really well captured, and then we forget the patient-centered care. It's not to digitize, a paper, but it's more about the patient care and also the care that the physician or the nurse or the pharmacist or the lab gives to the patient. So it's from patient charts to digital record to shareable data. We haven't gone this far in many of the places I worked in Africa, but in Europe and in the US, shareable data, and then learning about it, to use the learning. And nowadays we do a lot of work on surveillance, on AI, on decision support system, and then also research to go back to improve patient care. So why electronic health record matters to clinical care? EHR is a backbone of electronic health record. It has many things around it. For the patients, it's continuity of care. Many places I've worked over the years, especially for chronic patients, I feel very sad when their medical record disappears and then they are as if they are a new patient again when you have a paper record. When you have a well-used electronic medical record, the first place is the patient care. Then also for the physicians, patient context, alerts, results help the physicians to have a better care plan for their patients. For nurses, medication administration, observation, care coordination, and also for the system, the people who are working quality health care in our hospitals, it's very important also for them. So it's not just for one thing, it is a number of things that makes an electronic health record or medical record matter to clinical care. Some of the work I'm doing with the XiA project is to see and have a learning objective for learning EHR for different kind of for people who are in the hospitals, health centers, who are working for in-service training, and also for people who are going to be clinicians, nurses, and things like that. So the scope of, we have a number of modules that we are developing. The module I'm involved with to understand the purpose for EHR is to understand the general EHR characteristics, identify EHR function. This can be for an IT manager who's trying to develop an EHR, or it can be also for a medical doctor or nurses. Link EHR to primary and secondary data use. Primary use for the patient care, and the secondary use, it can be for surveillance or research or the kinds. And then recognize EHR as operational backbone. Architecture interoperability to works also on governance also. So the module that we are developing for different level of healthcare professionals, some in service and some can be pre-service, is for clinical use, interoperability, and governance EHR system. So in any EHR, when we talk about well-designed EHR, we have to think about it from the bedside, from the patient to the system intelligence. So from the point of care for the nurses, clinicians, allied health, for the clinical application, the architecture also have to take care from registration, consultation, orders, and the likes. And then the data layer, the patient master index, terminologies, structured data mode. These are very audit logs, very, very important. I was working in an EHR many, many years ago in one hospital, and the EHR was used because of the healthcare and the health law system was using it for criminal cases. So audit logs and who puts the data, who who signs the data, whatever they put for the patients, the audit log is very important. And then the exchange layers. There are a number of layers that at the moment are standard that needs to be used in Europe. This is in some of in the US, and also now little by little is coming to different parts of Africa. And then the user layer is very important, the clinical decision support, so that our clinicians, nurses, and others, and the researchers can use it in a better way. So clinical principle, don't implement an EHR as a database project. I have seen a number of EHRs, they are database projects, but it shouldn't be. This is to help the clinicians, the nurses, and the patients to implement a workflow, which is very important. interoperability, whether it is in the US or whether it's in Africa, is very important. We have a number of issues where different systems don't talk to each other. They don't, in the same hospital, we may have 5 systems and the doctors have to click 5 systems in the same computer. And also we have to think about standards and semantic interoperability, the kind that Brian talked about, LOINC and others for lab, for medical course and things like that. And then we have to talk the technical interoperability. We usually forget it, but how do 2 softwares talk in the same hospital or in the same clinic or primary health care? I think we're interoperability in the US, because with legislation and things like that, the system is trying to solve, but this is a big problem. And then in Europe, I think with EHDS, some of these problems hopefully will be solved or minimal. So why EHR readiness now matters in Europe and beyond is because the EHDS, because of the patient on one side, the primary users, the patients, the professionals, access to exchange to electronic health data care, including cross-border services. I mean, it's getting a little easier if I have a doctor here in Portugal and then I move to, you know, a European country, to Brussels or somewhere. Somehow, the idea is gradually my medical record can be seen and I can be my full picture can be seen with a doctor or a pharmacy in Europe. And I think COVID made this thing very easier and is coming because of EHDS. Secondary use for research, because we can only improve patient care if we can use the data for research and policy. So there are a number of initiatives that are being done, and EHDS by 2031. The idea is imaging and lab results, discharge reports, can be a cross-border exchange. Another thing that is EHDS is point of care. That is important. So saying that, I would like to go to some of the work that I've been doing and some of the challenges about EHR, whether you are in a high-income country or in a low-income country. Some of the challenges are infrastructure. In higher income countries, cybersecurity, inconsistent encoding, the data quality, workforce burnout, and also governance. Complex vendor contracts make it very difficult for hospitals and clinics to really expand on EMR. In low-income countries where I've been working, sometimes we talk about EMR, but we don't even talk about power and connectivity and hardware, as if by magic it will work. Unless you have this backbone, it's very difficult to say that, oh, we have an EMR system in the whole country or in the whole city. People forget that part. And then paper legacy, incomplete data. I was looking at the data from a facility last week, and the amount of information physicians put is very, very, very low. And with that, how can you do a patient care, And then the turnover because of salary and others. Today you see Dr. X, tomorrow you don't find Dr. X, and your medical record is not kept. And fragmented donor pilot, which is very, very, very difficult in Africa. We are having, it's not the system based from the country, but mostly are donor based, and that makes very difficult. And then the clinical risk part of it. Saying that, I would like to, for the last 15 years, I've been working on different parts of Africa on electronic medical record, with the caveat, like I said, that there is sometimes power difficulty, there is no generator, then they have to go back to the paper, and the people, the clinicians disappear, they are gone, the salaries are not that good. So clinicians are increasingly, they are optimistic that AI will solve some of their problems, and by adapting depending on safety, transparency, and governance. So implementation, clinical governance, workforce design, data standards, infrastructure, and the likes. So I want to show you a small innovation we have been doing. Africa is growing very much in mobile internet and connectivity and data use. So for the last few months, we have been trying to improve care at a primary healthcare level in Africa. And what we try to experiment is to do a decision support system using AI for primary healthcare. So just doesn't take a few minutes. Let me share my screen. What we have to see how to make it easier for clinicians to work. So in Uganda, the government of Uganda has a clinical guideline for all different healthcare issues. So with the colleagues, university colleagues there, recently we try to work to make it easier for primary healthcare workers, nurses, and others, if we can use the clinical guideline to give them to use it. This is an online web-based system, and also to use it on their mobile for some guidance. So we created this decision support system to make it easier. So for example, I will take one of the cases. It asks, this is in northern Uganda, you ask the system, it's a healthcare 2, which is below district hospital, and a 2-year-old came, you are a nurse, and with fast breathing, what should you do? So what it does is, when you analyze it, it will give you the general danger sign, the severity, the referral, where you should send it, and then it will even tell you where the next referral place you can do. So we have tested this system now in 10 facilities, and we are continuing to test it. And for example, a mother came, pregnant woman, 32 weeks, severe headache, blurring, and with a BP 170 or 110, what should you do? And you are at Health Center 3, which is a lesser than a hospital. So it immediately gives you, what you can do, immediate action, what you should do, referral, the danger sign is it can be preeclampsia, and then you send it. So we are testing this kind of system in different parts of Africa using the guideline. This is a simple AI that can be used to help primary healthcare physicians to do this. So there are a number of ways we can improve healthcare and use EHR for clinical care for primary healthcare level. Thank you very much. If you have any question, happy to answer. Thank you.
Perfect. Thank you, Wuleta, for showing this. Also, the demo of the CDS, the Clinical Decision Support System, shows what you can do with small code. Can already bring a lot of value to the clinicians. If you have any question, again, please share them in the chat or in the Q&A function. And with this, Juliana, I hand over to you for your intervention. I can share the slides. I can change the slides for you.
Yeah, please. Hello, everyone. Thank you for joining us in this discussion today. Yeah, so we can go. Timo, next slide. Okay, so I have my conflict of interest disclosure that I always state that my main conflict of interest is that I believe that I can change the world, and I've been working in education as the field, the tool that I'm using to change the world. I'm an internal medicine physician by background, but I'm working in improving the education of healthcare professionals, namely physicians. Next slide. So the classic case is this one. We have Pedro, this young man that is traveling around Europe, and he has asthma and regularly uses prescribed medication. And Pedro travels to Greece for a holiday. And during his trip, he has a severe asthma attack and needs urgent care. And if you are, maybe some of you are healthcare professionals in practice, so you know these patients. We meet them almost every day in the emergency department, someone that comes to work in Portugal from another country, someone that is on holidays. So this traveling moment should not be a break in the healthcare providers. And European Health Data Space comes to help us in dealing with this kind of situations also in our clinical practice. Next slide. Next. Okay, so why does this matter? And sometimes it's very hard to explain to the clinicians, because when we say something about electronic health records, the clinicians start to think that we are trying to convince them that they need to learn how to code and they need to learn how to understand and work with very complicated systems, but that's not actually the case. The European Health Data Space will create this European framework for health data exchange and reuse. And this will change the way clinicians access, share, and interpret data cross borders. Next slide. So this is really important because it seems that we are just talking about health data, but actually, next, we are discussing about a change in healthcare because the way we manage data have an impact on the way we treat patients and the way we approach people in healthcare settings. Next slide. So what are the challenges? We are moving from isolated systems in different levels of development, and we are aiming for integrated ecosystems that they do not gather data in the same space, but they easily gather and exchange data. And that's actually one of the most important topics that we are approaching in Europe right now. Next slide. So what are the challenges? Of course, the rapid growth of different electronic health records, the AI tools, telemedicine, but I would say that the two most important factors are the increasing importance of data-driven decision-making and also the adaptation to new workflows and new responsibilities. And this connects very closely to the clinical work that nurses, physicians, and other healthcare professionals do every day. Next slide. So what are the requirements for this European health data space implementation? So we need to understand the systems, and this is really important. So the health professionals cannot be totally gathered away from the way the systems are developed, constructed, and we have to trust the data that we are inserting and we are retrieving. And then we have to have integrate this data in the decision-making process. So these are new skills, new approaches that the healthcare professionals also will have to deal with. Next slide. And in my personal view, if you allow me, education is actually the tool that we can use to improve this. The understanding of the systems, it's really important for the healthcare professionals to understand how the systems work. It doesn't have to be like the technical requirements, but overall way of working. And this will allow the creation of trust, because without trust, we won't have healthcare professionals committed to creating this European health data space. And the other thing is the integration of this data, of these new systems, of this new exchange of data in the decision making. So education can help us in dealing with this, all these dimensions, and that's a bit what we are trying to do in XiA project. Next slide. So we will have enhanced clinical decision making, and this will be allowed by assessing a comprehensive range of data from the patient. So we will have access to different summaries from different countries, e-prescriptions, medical images, lab results, and discharge letters. And of course, this will also create new opportunities in terms of telemedicine support, since the information can travel or can be assessed. Actually, that's the most suitable concept, can be assessed in different countries. This will allow a very quickly interaction that will allow discussion with differentiated centers that can help us as clinicians dealing with complex or very rare cases. Next slide. So this enhanced clinical decision will improve continuity of care. And how is that? This will allow us to have patient journeys that are not constrained to the country. These journeys will be cross borders. We will have better coordination between primary, secondary, and specialized care, and mainly and also this specialized kit can be given abroad in other countries. And this will reduce the loss of transitions, because when Pedro, the young man that was on holidays in Greece, when Pedro comes back to Portugal, the records of his emergency department visit in Greece, they will be immediately connected to his records in Portugal. So his GP can access the information of this exacerbation of asthma that affected Pedro on holidays. Next slide. So this will actually, the European Health Data space will allow us to aim for the 9 pillars of continuity of care that were defined by the International Foundation of Integrated Care. It will be connected with, of course, the improvement of information and technology, with aiming for a shared purpose, help, the context promotion in context, having people as partners, because they will also have access to their information, improve teamwork and coordination of care. So this is not actually a transformation of work, and is a transformation of care also. Next slide. What are the requirements? So we need digital health literacy from the professionals to understand the infrastructures and the data-driven decision tools, data quality management, and this is really important because we have to ensure that the high quality of data that is inserted and structured in the systems, and of course it will bring ethical dilemmas related with handling data and a true understanding of privacy rules. Next slide. So we need to support the capacity building of the healthcare professionals to go in this transformation. And this can be done in 2 different ways: building capacity in continuous learning process, interdisciplinary training, and also dealing change. And this is all other science, the science of change. So we'll have to have change management with engagement and leadership from the institutions and from the government in helping the professionals to deal with these new challenges. Next slide. So this requires organizational change, because maturity is different from readiness, and we need to ensure that the systems and infrastructures, they are ready to this transformation. And several factors, they influence this readiness and this organizational change. And these factors include workforce capability, culture, and communication. And so often we leave culture as a second player, a second-hand player. But organizational culture is really important when we are trying to approach innovation and we are trying to work with different workflows. Next slide. So I've been using in the pedagogical interventions and transformation the theories of change, and Kotter's model of change is really important, because we need to create an urgency of change to guide the people along the change, to create a vision, communicate the vision, remove the obstacles, create short-term wins to motivate the team, and then consolidate and then create the change, and it starts over again. So we really have to deal with organizational as a whole. We have to make people motivated and trusting enough in the process and in the system to be able to change and contribute to this European health data space. Next slide. Yeah, so this is really important, and empower people to act on a vision. And the champions are very important in our institutions. We have the champions, people that they cannot be related directly to IT, but they are early adopters, or they are open to this change. So we have to grab them and to make us like co-creators of the educational materials, the educational process that we will bring to our organizations. Next slide. So the important thing here is to bridge the gap and build capacity. And this includes training projects, training programs, as we are doing in XiA, involving the clinical champions, peer learning to start the training and the transformation and the information to create a snowball effect inside the institutions, have simulated based learning where people can simulate the exchange of information, they can understand how the systems work. And this is something that sometimes misses a lot. And we come to the clinicians with the already program that they were not able to test or to simulate before. We say, after Monday, we are going to do things in this new way. And that can't be sometimes the best approach to this change and to transformations. They are required to be very embedded in the culture. And then the continuous professional development. So this is a never-ending process of creating capacity, assessing capacity, and helping the professionals to build more capacity and be more engaged in this process of change and the European health data space. Next slide. So my final message would be that really the European health data space depends on human capacity, and this is a clinical transformation, not only a technical one. And that's something that we need to really engage the healthcare teams and involving them, saying that these are tools to help their work. These are tools to help our patients and to show them the improvements that can be achieved, and not only showing this as really a very engaging technology or very wishful designs for the future. This is really to change people's lives. Next slide. I'll be happy to take any doubts or any questions that you have, and thank you so much for your attention today.
Thank you so much, Juliana, for this intervention. So you have Juliana's contacts here, her email address. You can also use the chat. I saw some people have posted questions on the chat, and we'll now move to the discussion parts. Thank you to our three presenters. If we can have you all three back on our digital stage, it would be nice for this part, the discussion and Q&A. So now all the participants, you can post your questions online and we'll respond to them. I believe there may be a way to unmute you. Oh no, maybe I cannot. But in any case, we will make sure we answer your questions. And maybe before going through the online questions, we can start with these three questions that I have prepared for the speakers, one each. And I'll start going back to you, Brian, and ask, in your view, what we in Europe can learn from the MENDS network, and especially the rollout of the network, because we have now passed the stage of drafting the EHS regulation, the text, etc., and we moved to implementation, and there we would really use some lessons learned from another country.
Yeah, thanks, Simon. I think briefly, because I could probably talk about this for a very long time, that some of the early lessons were that you can't. We often say we don't boil the ocean when it comes to HIE, so you can't create an entire statewide network overnight. It may take a few years, but start by connecting facilities, sharing that data, building that experience and reputation in a city or between some of the major cities, for example, or a couple of countries, if we're thinking about the EU-wide EHDS, to build those relationships with those demonstrated use cases of value. I think that's where we have found a lot of value. We started in the emergency department by connecting just emergency departments together, so that we could track sort of individuals who were primarily using emergency care as their primary care, and then it kind of grew from there. And so choosing those use cases and getting started to demonstrate that. I saw a question in the chat about trust. That really helps build trust and awareness amongst physicians, because we had some physicians at the beginning that were like, I never have patients that go across the town or in the next town over for care. That will never happen. And then, the third person who walks in the door had records, on the other side of the state, and we were able to pull those in and use them for care. So I think demonstrating those things and documenting it and building that that grassroots level. We have the policy now in Europe, which is the top-down approach, but building that grassroots level will be the next way to really broaden adoption of interoperable technologies.
Okay, thank you. So I understand also going step by step, small step by small step, kind of a piecemeal engineering approach, little by little, not trying to leapfrog directly to a perfect like end framework, which is actually the regulation doesn't detail a framework exactly to the last detail. So I think we are on the right track on this aspect. Does this resonate with you, Wuleta, Juliana, also?
Yes. I think trust is very important in EHR and also nowadays with the AI explosion that we are facing. To answer the second question that you asked, I want to give you 3 scenarios. A week ago, I spoke to orthopedic doctor here in Portugal, and then they are using AI for the imaging. The AI is doing well, and I said to him, do you trust it? Because I saw some of the result, and I said, wow. So he says, at first, I didn't trust it, and this is a surgeon. But he says, gradually, when I saw the result and then the loop with the human, with him, he's becoming to trust it, and he thinks that in few years it will replace a radiologist. That's what he says. 2 days ago, I had the same discussion in Africa, where they didn't have enough radiologists in a hospital that I was discussing, where the radiologist is trying to help a district, other hospitals, but he's one. He cannot go to all of them. So what does he use? Claude. So he uses ChatGPT nowadays, Gork and others to use for, to analyze. So for me, we cannot run away nowadays from a clinical decision support system, but it has to be trustful. But if people don't have anything else, they are going to use the big LLMs to do it. And you cannot say to them, they cannot use it. So I think AI and CDS is going to change both in high income and low income countries. But I think the trust with reputable organizations, we need to build it faster so that it doesn't replace the physician or the radiologist, but it can work hand in hand. So the scenario, the use case, what is for America or Portugal may not work for Africa, but we have to think of what is the use case for them so that we can make sure even the patient there, they benefit, instead of somebody going to Claude and saying, please tell me what is the reading of this image. So I think we are in the IT is moving faster than the medicine, unfortunately.
Right, and this links to the third question, which is also reflected by the question of Beatrice in the chat. She, from her perspective, so she's a healthcare professional in Germany, and she feels like there is still a big lack of awareness about the European health data space. And this links to the third question, how to move clinicians from passive users of digital tools to active co-creators of future digital health systems, if they're not even aware. Maybe, Juliana, this one is for you.
Yeah. Yeah, actually, I think that raising awareness is something that we are trying to do with the European projects, but I think that we really have to do it by using the champions in the different institutions, because it's really hard to get in touch with such a big population as the whole group of healthcare professionals in Europe. So, but I think that really the important thing to move the clinicians, healthcare professionals from passive users to co-creators is really to explain them that this is not only about technology, this is about patients and patients' outcomes. Because when we connect the effect of these digital tools with patient outcomes, then the healthcare professionals, they become really engaged and involved. They just don't want to learn about engineering or coding or something like that. They sometimes are scared because they think that if we tell them about digital health, they will be teaching them all range of computer things and strange things that they don't want to know about. I think that is really connecting with patient outcomes. And we all that are here today, because we maybe are champions in this field, we all have a role to play in disseminating the information about these projects and the European health data space.
You heard Juliana, so all of you who are clinicians in the audience, also not clinicians, but you may be champions. So everyone has their small role to play to step-by-step advance onto the implementation of this regulation that will improve, hopefully, all of the outcomes for patients and the clinicians' workflows. So regarding the time now, I would like to close the session. Thank you, everyone. Thank you, the speakers. Thank you to the participants. Invite all of the participants to share the feedback. It's just 2 questions about this session, so we can improve for the next time. This was the second of a series of webinars. We're going to have more. And you can scan this QR code or use the code that is on the left side of the slide. Go to menti.com and share your feedback there. This slide will also be part of the slide deck that I will be sharing with you by email with all of the people who have registered actually for a follow-up email. So you can browse through the information and material that was presented by our speakers. And finally, we have a slide with upcoming events. So we have a parallel webinar series in our XiA project that is developed in collaboration with Hospitals on Fire and HL7 Europe. Implement the EU Lab report in your hospital. The next webinar is going to be about implementation guides. We have Giorgio Cangioli from HL7 Europe speaking. This is on the 29th of May. You're free to please register. This is very useful probably for clinicians because we work with Hospitals on Fire. You will see this is a very active community and we kindly invite you to join. We will be also represented in Paris from the 19th to the 21st of May at Sant'Expo, and in Italy, Genova, at the Medical Informatics Europe, MIE, which is a place where some of you may be also going if you do research. Here again, the same QR code that I presented at the beginning of the session, and with this, I invite you to scan it, and I can free everyone, and thank you again for joining. Thank you to our speakers, and please stay connected with the project. And enjoy the afternoon.
Thank
you.
you.
Bye-bye.